We're going to start on the background of sleep apnea. So, starting with obstructive sleep apnea. Obstructive sleep apnea is the most prevalent form of sleep disordered breathing, and it's primarily caused by repeated episodes of upper airway obstruction during sleep, despite the ongoing respiratory effort. The etiology of OSA includes a combination of anatomical and neuromuscular factors. Common risk factors are obesity, enlarged tonsils or adenoids, a thick neck, a retrognathia, which is a recessed jaw, and increased soft tissue around the airway. In obese individuals, the excess fat deposits in the pharyngeal walls and tongue that can be reduced into cross-sectional area of the airway. When the pharyngeal dilator muscles like genioglossus relax too much during sleep, the airway closes and collapses, especially during REM sleep when the muscle tone is at its lowest. Pathophysiologically, the airway obstruction leads to intermittent hypoxemia, which is low oxygen, and hypercapnia, which is high CO2, which triggers arousals from sleep as the body attempts to restore to normal breathing. These frequent arousals reduce the time spent in deep and REM sleep. Over time, OSA contributes to sympathetic nervous system overactivity, systemic inflation, insulin resistance, and hypertension. Patients typically report loud snoring, gasping, choking during their sleep, and excessive daytime sleepiness. Some experience morning headaches, difficulty concentrating, and mood changes. So anatomically, the upper airway becomes a dynamic collapsible segment due to the loss of neuromuscular control during sleep for obstructive sleep apnea. Now we're going to talk about central sleep apnea. Central sleep apnea is different from OSA in that it is not caused by physical obstruction of that airway, but rather by a neurological failure to generate or transmit the respiratory drive from the brainstem to the respiratory muscles. CSA is often associated with conditions that affect brain's respiratory centers, such as heart failure, stroke, brainstem lesions, or chronic opioid use. It can also be idiopathic. A major factor in CSA is instability in the feedback mechanisms that regulate the blood gases, particularly sensitivity to the CO2 levels. This can lead to periodic breathing patterns like Cheyne-Stokes respiration. When it comes to the pathophysiology of CSA, it involves transient reductions or complete cessations in ventilatory effort due to absent signals from the medulla's respiratory centers. This causes the pauses in breathing without the typical struggle seen in OSA, resulting in hypoxemia, sleep fragmentation, and disrupted sleep cycles. Since there's no obstruction, patients typically don't snore, but they may experience frequent nocturnal awakenings, insomnia, daytime fatigue, and shortness of breath during their sleep onset. So anatomically in CSA, the airway remains open during CSA events, but the diaphragm and intercostal muscles receive no signal to initiate a breath, distinguishing it from OSA. When it comes to mixed sleep apnea, MSA, or it's also called complex sleep apnea syndrome, it's a hybrid disorder So it begins with features of obstructive sleep apnea, but then it reveals central apneas, either during diagnosis or once the positive airway pressure therapy begins. So in many cases, central events appear after initiating CPAP therapy in patients with OSA, which leads to what's called complex sleep apnea syndrome. The exact etiology isn't really fully understood at the moment, but it appears that it can be related to instability in respiratory control systems, heightened sensitivity to CO2 levels, and changes in respiratory effort followed by upper airway stabilization. So in terms of pathophysiology, MSA starts with obstructive mechanisms similar to OSA, but also features a loss of respiratory drive as seen in central sleep apnea. So initially, the airway collapse causes obstructive apneas, but once CPAP opens the airway, central apneas emerge, possibly due to an overcompensated ventilatory response and an unstable feedback loop. Symptoms are both similar to OSA and CSA and include snoring, gasping, insomnia, morning headaches, excessive fatigue, and sometimes cognitive changes. So anatomically, MSA represents a dysfunction in both the upper airway structures as seen in OSA and central respiratory control centers as seen in CSA, which create a complex interaction that complicates diagnosis and treatment. So to break it down, the major difference among OSA, CSA, and MSA is the source of the respiratory disruption. So in OSA, the problem is anatomical and mechanical since the soft tissues of the pharynx collapse due to gravity and decreased muscle tone, especially during REM sleep. While in CSA, it's a neurological failure where the brain does not signal the body to breathe, despite having a patent airway. MSA is a combination of both, where airway obstruction and central signaling failure coexist or evolve into each other.